Okay, so today we have the endocrine section from the critical care.
Okay, sir.
So this is your scenario. Kindly review it and then we will start.
Okay. Yes, sir.
Okay, so can you tell me what are the layers of adrenal cortex?
There are three layers for the adrenal cortex. It is a zona glomerulosa, zona fasciculata, and zona reticularis.
Okay, so can you tell me about the actions of aldosterone?
The aldosterone increases the sodium reabsorption and decreases the sodium absorption, decreases the potassium absorption, and it also maintains the fluid balance. It also maintains the acid-base balance.
Okay, so what is the action of cortisol?
Sir, the cortisol has a wide range of action. It increases the appetite, then leading to weight gain. It increases the blood pressure, leading to hypertension. It increases the insulin resistance, which leads to increased blood glucose levels and leading to diabetes. If in already diabetic patient, there will be poor control of blood sugars. There will be decreased fibroblastic activity leading to impaired wound healing and decreased immunological activity leading to immunosuppression and osteoporosis. Yes, osteoporosis, increased risk of infections.
Okay, so can you tell me about the hypothalamic pituitary adrenal axis?
Yes, sir. The pituitary adrenal axis. Okay. Hypothalamus secretes a corticotropin releasing hormone, which acts on the pituitary gland, anterior pituitary gland. It releases the ACTH hormone, adrenocorticotropic hormone, which acts on the adrenal cortex, leading to the release of the cortisol. When the cortisol levels increases in the body, there is a negative inhibition to the pituitary gland and the hypothalamus, leading to decreased secretion of the CRH and ACTH.
Okay, so what advice you will give to patient who is going to be started on steroids?
Uh, when the patient is going to be started on steroids, we'll ask the patient not to stop the medication abruptly and to taper the dose and then stop it slowly. The next thing is we must inform any doctor which the patient sees later for any other complaints. Then we must mm, inform the patient regarding the muscle weakness and weight gain, fluctuation in the sugar levels, increased risk of blood pressure in the patients with the steroid intake. Then there could also be an increased risk of bone fractures. Then there could also be reactivation of any previous infections like TB or candidiasis.
Okay, so can you define what is Addisonian's crisis?
Yes, sir. Addisonian crisis is an acute reduction in the circulating steroid hormones, and it can be primary or secondary. The primary is when the body's meat demand is not met by the cortisol levels. Then in secondary, it could be due to any infection, trauma, or surgery, or due to a sudden stoppage of exogenous steroids.
Okay. So can you tell me about the causes and the clinical picture of the Addisonian crisis?
Uh, okay, so the clinical picture is the patient can have abdominal pain, nausea, vomiting, confusion, convulsion, and shock. Then causes the abrupt stoppage of the steroid medications and um, yeah, sir, abrupt stoppage of medications.
Okay. So what is the management of Addisonian's crisis?
I will manage the patient according to the CRIS protocol, the ABC protocol. I will check the airway breathing and ventilation and the circulation of the patient. I will start the patient with IV steroids. Initially, 100 milligrams of hydrocortisol IM or IV is given, followed by a continuous infusion of 200 mg of hydrocortisone over 24 hours. Then I will also start the patient with IV fluids. 1 liter of isotonic saline is given initially, followed by IV fluid according to the need of the patient, like dehydration or correction of electrolyte imbalance.
Okay, so what steps you can take to prevent Addisonian crisis from happening at the first place?
So we must not stop the medication which the patient is taking. If the patient is on steroids, we should not stop the medication abruptly. And when the patient is going for any surgery, we should try to double the dose prior to surgery. So we should first give 100 mg cortisone at induction and then add the 200 milligrams of infusion over 24 hours. Then, after the surgery, when the patient breaks the NPO, we must start the patient on oral steroids. So, if the surgery is a complicated surgery, we should give double dose steroids for 1 week, or else we should give for 48 hours if it is an uncomplicated surgery.
Okay. So you did the answers very well.
Thank you,
So
sir.
just keep the pace and keep
Yes.
on practicing. Okay.
Okay, sir.
So this is your next scenario. Review it and then we will start.
Mm. Okay, sir.
Okay. So explain the hypothalamic pituitary thyroid axis.
Hypothalamic pituitary thyroid axis. Okay. So from the hypothalamus, there will be release of the thyrotropin releasing hormone, which acts on the anterior pituitary gland, which in turn releases the thyroid stimulating hormone. The thyroid stimulating hormone acts on the thyroid gland, and from where T3 and T4 hormones are secreted. When there is an increase in the levels of T3 and T4, there will be an inhibitory action on the pituitary gland and the hypothalamus, leading to decreased secretions of the TSH and TRH.
Okay, so can you tell me about the difference between T3 and T4?
The T3 is the inactive. T3 is the active form, and T4 is the inactive form. Then T3 is found only 5% of the hormone is T3. The rest is T4. Then there is more protein binding happening in with the hormone T4, but less protein binding in T3. Less protein binding of the T3 hormone,
Okay.
so that it is actively available.
Okay. So can you tell me about the steps which are involved in the synthesis of T3 and T4?
Yes, sir. So the body absorbs the iodide form. Iodide ion enters the follicular cells of the thyroid gland. Then it gets converted into iodine with the help of tyrosine peroxidase enzyme. After converting into iodine, it combines with tyrosine to form monoiodotyrosine and diiodotyrosine. Monoiodotyrosine plus diiodotyrosine forms the T3 hormone, and two diiodotyrosine molecules forms the T4 hormone.
Okay, so what type of anemia you will suspect in this case?
The type of anemia will be macrocytic anemia due to uh, the um, uh, mm, the non-division of the cells due to the deficiency of vitamin B12. It is due to the anti-parietal cell antibodies, which leads to decreased formation of the intrinsic factor, and hence there will be decreased hemoglobin but increased MCV, leading to macrocytic anemia.
Okay. So what are the different causes of hypothyroidism?
Uh, the causes can be divided into primary and secondary. The primary is due to um, four causes. It is iatrogenic, idiopathic, uh, iodine deficiency, and autoimmune. So, in iatrogenic, it can be due to surgery, drugs, and radioactive iodine therapy. Iodine deficiency is nutritional, and autoimmune causes like Hashimoto's. There can also be the issues regarding in the development of thyroid gland, and also absence of thyroid gland equivalence thyroiditis. These all comes under primary hypothyroidism. When coming to secondary hypothyroidism, it could be due to the failure of hypothalamus or the pituitary gland.
Okay, so what are the signs of hypothyroidism?
Mm, Signs of hypothyroidism. There will be bradycardia. Then there will be the patient will be having muscle weakness. There will be intolerance to cold. Mm, then there will be constipation. Weight gain will be there. Mm, mm, and there will be loss of lateral one third of the eyebrow, hair loss, then dry skin. There could be pretibial myxedema.
Okay. So patient with hypothyroidism is not compliant to their medication and they are come to emergency surgery. So what are the risks that you will keep in mind while taking the patient for emergency surgery?
Patient with hypothyroidism. We have to first make the patient euthyroid before taking the patient for surgery. So, we can do it by using propranolol, steroids like dexamethasone, and thionamides. If the patient is having in the during an emergency surgery, there could be complications. Mm, so the early complications can be anemia and heart failure. The intraoperative complications can be bleeding. Um, there could be a decreased heart rate, bradycardia, decreased BP, hypotension, decrease in the temperature, hypothermia.
Okay.
Post-operatively, there is reaction to the anesthetic drugs can occur. There could be thyroid myxedema coma and delayed recovery from anesthesia.
Okay, so who will you involve in the care of this patient?
Sir, I will involve the endocrinologist, the surgical consultant, the patient's own GP, and his family members. Yeah.
Okay, so how can you increase the compliance with the treatment?
So we have to first optimize the treatment. We have to give a simple regime which consists of a single dose of the thyroid medication, then on a fixed time. And also, we must inform this to the patient. We should discuss this with the patient and also the GP. We have to involve the GP and also discuss it with the family members. We should also inform the patient that if there is any drug default, then the patient can have the recurrence of the hypothyroidism. And we should also follow up the patient regularly.
Okay, so you did the scenario very well. Just a few things that I would like to add that
Okay, sir.
for the causes of hypothyroidism, for the
Okay.
primary focus on the eyes. Okay, so it could
Oh,
be iatrogenic, it could be
okay.
iodine deficiency, it could be idiopathic, or it could be autoimmune.
Yes, yes.
Okay. So,
Yes.
in the signs of hypothyroidism, everything is going to be on the lesser end. In the GID, there will be constipation, there will be
Yes.
bradycardia, there will be muscular weakness, and the eye signs and the premyxillary edema, along with edema over the shin. Okay,
Okay.
so
Okay.
these things are a bit important with cold intolerance.
Okay, sir.
Now, regarding the
Okay.
question that the patient has hypothyroidism and they are not compliant to their medication and they have come to the emergency for anything that is emergency. It could be a obstructed hernia, it could be an RTA, it could be an open fracture. So, what will be your concerns? So, primarily, you said that you will be making the patient euthyroid. No, you will not have that much time. Okay.
Okay.
So
Okay.
you will just be telling about the risks. So the patient will have
Okay.
increased risk of heart issues because of the
Okay.
pre-existing anemia, which we have
Okay.
discussed that this patient was having macrocytic anemia. Then
Mm.
intraoperatively, the patient can develop myxedema coma with bradycardia, hypotension, and hypothermia.
Okay.
And post-operatively, you said the right things that there will be delayed in the recovery. The patient can
Yes.
have confusion and
Oh,
poor wound healing. Okay, so that
oh,
was the question that you have to work on.
okay. Okay, sir.
There are a few more questions that what are the complications of thyroid surgery? Like this question can be tested in hypo and hyperthyroidism scenario. So it's a like general question. What are the complications
Okay.
of thyroid surgery?
So, in early post-operative, the patient can have bleeding, injury to the recurrent laryngeal nerve, injury to the superior laryngeal nerve. There could be tracheomalacia and airway collapse. If it is the long-standing thyroid swelling, and there could also be infections. In the in late complications are the patient can after the removal of the thyroid gland, the patient can go into hypothyroidism, hypoparathyroidism if the parathyroid glands are injured or accidentally removed, also leading to hypocalcemia.
Okay, so this is your next scenario. Kindly review it and then we will start.
Okay. Yes, sir.
Okay. So what are the types of diabetes mellitus and briefly describe their pathogenesis?
Okay. So the two types are type 1 and type 2. Type 1 is less common. It is seen in 5% of cases, and type 2 is more common, seen in 80 to 90% of cases. Then um, the type 1 is due to absolute deficiency of the insulin levels. Insulin secretion due to destruction of the pancreatic beta cells, autoimmune destruction. So there is an absolute deficiency of insulin. In type 2 diabetes mellitus, there is a combined insulin deficiency or insufficient release of insulin for the according to the need, and also peripheral resistance of the insulin. So this is a relative kind of insulin deficiency. And pathogenesis. mm, Pathogenesis of each means I didn't understand.
Like in type 1, there will be beta cell destruction, and in type 2,
Okay.
there will be inadequate compensatory
Oh,
response to insulin. So that is just
oh,
like a brief pathogenesis.
okay, okay.
Okay, so what is the function of insulin and what are the other hormones which affect the blood glucose levels?
The function of insulin is to transport the blood glucose into the peripheral tissues. That is a principal action. So there are also other hormones. The other hormones are glucagon, then the pituitary hormone somatotropin, then the cortisol, and epinephrine and norepinephrine. So in the insulin also increases the protein amino acid uptake. It also increases the protein synthesis. Hence, it is also regarded as a growth hormone. Then it also increases the lipogenesis. It increases the deposition of lipids into the cells and also the oxidation of the lipids inside the cells. Uh, that's it.
So other hormones which affect the blood glucose level?
Glucagon, then somatotropin, there's a pituitary hormone, then epinephrine and norepinephrine, then one more, cortisol.
Okay, so what precautions you will take in a diabetic patient who is going for surgery?
Uh, so I will make sure the patient is given priority in the OT list. That is, the patient is first in the OT list. Then I will also identify the patient according to the WHO surgical safety checklist. Should we should avoid the need of overnight admissions, and also NPO should be for 6 hours. Only one meal should be missed. If there is a chance that the patient misses more than one meal, then we should start the variable dose insulin infusion therapy to the patient. Then we should help the patient recover soon and start enteric feeding by giving the patient analgesics and antiemetics. Then we should also give good fluid resuscitation. We should start the patient on half 0.45 percentage of saline and 5% glucose along with some added KCl. Then we should also check the blood glucose levels during and after the surgery. It should be checked hourly. And we should also check other levels like ABG and potassium levels.
Okay. So what type of insulin you will use during the variable insulin infusion?
A short acting, sir.
Okay. So what are the immediate and late post-operative complications which are likely to happen in this patient?
Immediate complications, so the patient can go in for hypoglycemia or hyperglycemia. The patient can go into hyperglycemic hyperosmolar syndrome and also DKA. DKA happens in type 1 diabetes patients. And hyperglycemic hyperosmolar syndrome occurs in type 2 diabetic patients. Then there can be hyperkalemia or any electrolyte imbalance. Then post-operatively, the patient can have infections. Mm, that's also wound infection.
Okay. So post-operatively, who will you involve in the care of this patient?
I will involve an endocrinologist along with the patient's general practitioner and his family members.
Okay. So what specific investigations can help you in managing the diabetic mellitus patient?
Specific investigations like HbA1c, then blood glucose levels, and electrolyte levels can help the managing the patient.
Okay. So what do you think that this patient might need if their diabetes is not well controlled by the oral medication?
We will need a insulin therapy, like a variable rate insulin infusion therapy.
Okay. So regarding the investigations, you can add ABGs, potassium, and blood glucose levels in addition to HbA1c.
Okay, okay, sir.
Okay? Like potassium levels are very important.
Okay, sir.
Okay, and the most high yield question from this scenario is the intraoperative or preoperative precautions for a diabetic patient.
Okay, sir.
And one important thing that this point will be an overlap in the procedure part of the MRCS Part B. Okay. So when you will be
Okay,
asked to list a patient, then you will be
okay,
keeping these things in mind.
okay, okay, sir.
Okay. So this is your next scenario. Kindly review it and then we will start.
Yeah. Yes, sir.
Okay, so why this patient is having tachycardia?
The patient is a case of hyperthyroidism. Uh, so there is increased thyroid hormone T3 and T4, which leads to increased heart rate and increased cardiac contractility and decreased systemic vascular resistance.
Okay, so can you tell me about the clinical picture of hyperthyroidism?
The patient can have tachycardia or palpitations, then diaphoresis, diarrhea, heat intolerance, muscle weakness, myxedema. Mm, then eye symptoms like eye pain or bilateral exophthalmos.
Okay, so outline the basic physiological role of thyroid hormone.
Physiological role, like mm, like I didn't understand.
I like the basic role in everyday life activities.
It helps maintain the heart rate. Then it has a role in basal metabolic rate, and also the in maintaining the mental state of the patient, along with mm, weight management. Uh,
Yes.
and also regarding hypertension.
Okay.
Yes.
So how will you investigate for this patient?
So first I will do the thyroid function test. So initially I will do the TSH, which is the initial investigation of choice, followed by T4. Then if it is found to be normal, then we can go ahead and do T3. And we should also check for the anti-TSH antibody, and also complete blood count, like the hemoglobin levels, the leukocyte levels. The leukocyte level could be low or normal, and platelet levels. Platelet level could also be low or normal.
Okay, so will you perform the surgery in this patient?
Um, no, so first we have to make the patient euthyroid before performing a surgery. So the patient is in a thyrotoxic crisis. It looks like the patient is going into a thyrotoxic crisis. The temperature is 39.5, so hypothermia is there. Heart rate is 150 per minute, so there is tachycardia, and 168 by 92 BP, which is hypertension. So first we have to manage the patient medically by giving IV paracetamol for management of the um, hyperthermia. Then for reducing the mm, heart rate, we have to start the patient on propranolol to manage the palpitation and the anxiety. Then we can start with thienamides, like methimazole, carbimazole, and propylthiouracil. Then that's it
Okay.
in this patient.
So who will you inform regarding this issue?
So I will involve the endocrinologist. I will also involve the anesthetist and the surgical consultant.
So
If
patient,
needed, the ITU
Mhm.
physician also,
Okay.
ITU
So
consultant also.
okay, so patient has been operated and they have developed a thyroid stall. So what will be your management?
Uh, in thyroid storm, the patient will be having increased temperature, and the vitals will not be stable. Like there will be tachycardia and hypertension. So first we have to manage that. So we must start the patient with IV paracetamol to decrease the temperature. The next immediate line of management is by giving IV propranolol to manage the tachycardia, and uh, the and also start the patient on thionamides, mm, like methimazole or carbimazole. Then also we can if we can give steroids if needed.
Okay. So
Yeah.
when previously I asked you that will you do the surgery, in that you were just supposed to tell that I will make sure that the patient is euthyroid and I will consult with my consultant and the anesthetist and the endocrinologist.
Okay.
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 So you just added on there what will be the clinical picture and what will be the management. Okay. So if you do this on the exam day, it will waste your time. Okay. Because
Okay.
they will ask you the same questions again. But if
Okay.
you answer it in that question, it might not be marked. Okay. So the question was that
Okay.
will you do the surgery? So the answer is yes, I will perform the surgery when the patient is euthyroid.
Okay.
Okay. And
Okay.
regarding who to inform. So, for example, this was your patient who was on an elective list. But when the labs were performed, he or she had hyperthyroidism. Now, the
Okay.
patient's information needs to be communicated with the operating surgeon, with the
Okay.
anesthetist, with the OR team. Okay, because they will be preparing the OT for this patient.
Okay,
And
okay,
it needs to be communicated with the patients and their attendant as well.
okay, sir.
So
Okay,
whenever you are asked that who will you inform, and the patient is a surgical patient, so these are 3 to 5 areas which you have to touch in your answer.
okay.
So that's an
So I
important thing.
added surgical consultant, but along with that, we have to add the OR team also.
Yes, the anesthetist, the OR team, because they will be waiting for this patient.
Okay, okay, sir.
Okay, so rest of the stations were very well prepared. So any question?
So, regarding the hypothyroidism, you said like we don't manage in like emergency management also. Uh, can we give the patient dexamethasone like to make the patient euthyroid?
Yes, in case of the hypothyroidism, you have to quantify that whether it is a mild to moderate or a severe type. Okay. Then you
Okay,
will add thyroxine accordingly.
okay,
So
okay,
if it is mild to moderate, you can add 50 microgram.
okay.
But if it is a severe case, then in addition to thyroxine, you will give a dose of dexamethasone as well, like any
That's
steroid. Okay.
mhm,
To
mhm.
cover up for the surgery time so that the
Okay,
patient does not have a delay in their surgery.
okay. Because we can't actually, in severe cases of hypothyroidism, we usually postpone the surgery, but in emergency, we can't, when we can't postpone the surgery, so then we have to give thyroid D4 along with the steroids right now.
Exactly. Exactly. So basically, they are testing you for the concepts that are you
Okay,
good with the concepts or not?
okay, sir. Okay.
Okay.
Oh, yeah, okay, sir. Screen is. Okay. Thank you, sir.
Thank you.